Yeah, we have time for a couple questions, right? So thank you very much. And I think I know what your answers may be to this, but I'm going to ask you each, and I'll move back up this way, starting with you, Ms. Montanaro. Can you name one thing that you would like to see done better with the private sector, the public-private partnership, and maybe one thing that you think the federal government could help you with in the kinds of things you're talking about at the state level? And then I'll ask each of you down the line to address that.
Yeah, I think in the private sector, we really would like to engage our commercial insurers and our Medicaid managed care companies in effective strategies. Dr. Benton mentioned the use of a chronic care model. We run 5 opioid addiction health homes built on the chronic care model in the Medicaid program. I'd really like to see that integration happening in the private sector. So I do think that it's a challenge for EAP programs and for commercial insurers to look beyond utilization management and traditional telephonic care management, which is not going to be enough to reach this population and provide effective treatment. So we'd like to engage them in that partnership discussion and really look at some of the things that have happened in Medicaid because of the flexibility and engage other payers in those strategies. On the public sector, I think we need to continue to look for the addressing of the rising rate of the cost of medications, including naloxone, but also buprenorphine. We're going to see that jump, and a few other things. Really, there's a role for the federal government to step in on drug pricing and also on the prescribing regulations, particularly around buprenorphine, that are really limiting the use of that medication today.
Thank you. Dr. Delphin Rittman from Connecticut, what's your wish list for private sector, public sector, and maybe federal help?
So in terms of private sector, I think a greater integration, I mean, this is one thing we're working on within the public sector, but greater integration of primary care and behavioral health. I think because of the separation and the gaps there, it's sometimes difficult to identify when addictions or when problems are starting. So I think a greater integration really could help with identifying individuals who may be beginning to develop problems. On the public, or on the public side, I think data sharing, being able to really share, both gather and share data across different sectors would be really critical. Particularly for individuals that might be in a crisis situation, to be able to identify the different prescriptions that individual may have, or just data sharing across the board, I think may help with being able to identify challenges that individuals having, as well as, and other systems they may touch, as well as medications that they may be using. So I think those two areas would be.
Is that something you think we need federal legislation for, to cover the data sharing? I know Senator Markey talked about that earlier. And then, of course, when we always run into the confidentiality issues that are huge too, but it seems like it needs to be tackled.
It does. I mean, I think it needs to be at the state level, and absolutely, if federal legislation could help with that, I think that would be significant. It's definitely a challenge area that we see across the board within our state. Just needing to be able to share data more across different systems and segments would be really valuable.
Dr. Burrell in Massachusetts?
First in Massachusetts, I want to point out that we have a long history of excellent private-public partnerships where we've really developed some great public and private programs that have been real partnerships and have some real best practices. So I want to acknowledge that. And, I see my colleagues from Boston Healthcare for the Homeless in the back who have done some great work with behavioral health integration. I see the folks at DMIC who have on-site medical, mental health, and substance use I see Colleen LaBelle, who runs the OBOT program, integrating MAT in the health centers, my colleagues from ABH, Association of Behavioral Health. We talked earlier about Mass Medical. We have many insurers in the room, and we really do have a good working capacity together. I think that we now have to work to take those one-off best practices and really turn them into a state model together and work towards that in a very integrated way. From the federal level, I really want to emphasize this point about data sharing. So the CFR 40 and other restrictions at the federal level put in place with very good intentions that are inadvertently creating silos that we are now stuck in and can't then get patients the treatment they need. That and anything at the federal level to help enhance medication-assisted therapy.
Rachel?
Well, I'm taking all of your ideas and bringing them back for one. Secretary Burwell is required to love all of her states the same, but I am required to love my region the best. And all of New England, I think, is certainly leading the nation in a lot of these best practices and a lot of these integrated models. So I will just sort of speak from the peer level that better primary and behavioral health integration is critical to getting our arms around this. Greater, almost full participation in the prescription monitoring program. We have very good participation in New England, but that is not the case with the prescribers and providers. And better training for prescribers and providers. There are tens of thousands of doctors and others in this field who have never been trained in prescription abuse training. So that's another thing that the federal government has a lot of great pilots going on around the country. And we want to hear your best practices. We want to federalize them and we want to fund them and see how we can begin to make things a lot better and easier for people seeking treatment.
One more question? Sure, yeah, we're happy to take. Yes.
Is this on? Good morning, everyone, and thank you so much for this conversation. And Monica, you really hit on all the key pieces that I wanted to hear in terms of how we can think about our partnerships. One of the things is, my name is Maisha Minter-Jordan, and I'm the president and CEO of the Dimick Center. We operate one of the 2 detox facilities in Boston, one of 29 in the state, and serve approximately 3,000 individuals each year in recovery. We also have 4 halfway houses on our campus, as well as outpatient addiction programs. One of the things that I'm looking for are opportunities to partner with the private sector regarding when you need to get someone into care, getting them to us, and the ability for us to be able to let the private sector know, let our health insurance partners know when we have beds to be able to get people into those beds as quickly as possible. So I'd love to hear some thoughts about how we can deepen that partnership in real time to be able to get people directly into care.
Thanks for that question, and thanks for the great work you do at the Dimick Center, by the way. I know most of the people in the room know that, but a great model for all the things we're talking about today and beyond that. So any of our panelists want to jump in? Dr. Burrell?
I want to talk a little bit about a hotline. So we have a hotline available through the Department of Public Health where individuals can call and find out about services in their area. But we need to be able to have a better real-time capacity on that line. So we're working now with our Mass Health colleagues to look at how we can make it more real-time. So when an individual calls in, whether it's a provider or a patient looking for services, they can know that day where beds are available. And because of the way we work across the state, it's a project to put that together, but that kind of starts to address that as how we can communicate better about what the availability is, because again, it's getting the right place at the right time. That concept is, we do have some work to do there.
And the other states, you want to comment on how that works?
In Rhode Island, we do have a priority list for the limited amount of treatment beds, but even as important, I think what we're working on is the engagement of our health plans in this very activity, both on the we're a Medicaid managed care state and also on the commercial side. So what happens right now is wherever the patient shows up in the healthcare system needing treatment services, it usually is up to that provider, whether that's the ER or a hospital or that is a primary care physician, to call around and try to figure out where beds are available. If they happen to call the department, we have a priority list, but what we really need is for the plans working together through Current Care, our we have a very strong infrastructure in our current exchange, health information exchange in Rhode Island, to really be able to pull up a priority list and work together on prioritization and placement of people, both in residential care, which is one issue, but even more importantly in outpatient care. So while we fan out with a lot of different strategies like peer recovery coaching and all sorts of outreach activities, we don't have a systematic way to engage people in the therapy they need and to encourage primary care physicians to be able to be connected with therapy. So they're often at a loss. What do I do? Where do, you know, and they're looking for a handoff, and what we really need is the collaboration between therapists connected with that primary care. And we really see managed care as a place where they can make those connections and play that role because of their line of sight across our system. And we only have 4 participating plans in Rhode Island, so it wouldn't be that hard to come together and do that.
So thank you. So will you all join me in thanking our terrific panel for their great contributions today? Thank you.